A very good morning to all of you. Welcome to another episode of CBD webinar series organized by Society for Health Research and Innovation. First of all, I'll introduce all with the basic housekeeping rules. The webinar link will be available from 9:15 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. This is to improve and maintain the standards of the CBT programs conducted by Shri. Thanking you for the strict adherence of the CPD regulations and uh, your kind compliance. If you have any questions, you can type it in the chat box, and your questions will be answered at the end of the lecture. Today, the topic is heat emergencies. Today our guest speaker is Dr. Varuna Madhushanka, consultant emergency physician of National Hospital Accident Service, Sri Lanka. Over to you, sir.
Right. Thank you very much, Akit, for introducing myself. So today I'm going to talk about heat emergencies and a little bit of basic life support. Let me share my presentations. I think you all now can hear me very well and you all can see my presentation. So next 1 hour, what I'm going to do is I'm going to talk about heat-related emergencies. As well as at the end of my lecture, I will discuss if you find a patient outside the hospital with unresponsiveness, how to approach that patient and how to provide the basic life support. So I'm Varuna, I'm Dr. Varuna Madhushanka. I'm a consultant emergency physician. At the moment, I'm working at the National Hospital Accident Service. Let's move on. Yeah. So why as Sri Lankan doctors or healthcare practitioners, these heat-related emergencies are important? Because Sri Lanka is an tropical country. We live in a tropical country, and especially this month, February, April, August, these months, environmental temperature is very high. As well as most of the Sri Lankan population, people, they do their jobs or their employments outside the offices. They are not doing the white collar jobs. They do labor jobs and the jobs that attend daylight at the outside, exposing to the environmental temperature. So, from my Sri Lankan clinical experience, I have seen many patients with heat-related emergencies or heat-related illnesses. However, as doctors, as primary care doctors, wherever you work, either emergency department, medical ward, accident service, or even in your general practice, you might see patient with heat-related emergencies. But sometimes, if you don't have adequate knowledge and skills related heat-related emergencies, then you might miss these patients. That's why we should have at least a basic idea of heat-related emergencies, right? So I think you all can see this picture of like a person who exposed to the hot sun. So these days, if you can, I think definitely you all will experience the warmth and the brightness of the sun, right? So this person, I think he is working outside, and then he looks very exhausted, and he's sweating a lot, right? And then there are no shade enough nearby him to get some shade to protect from the sunlight. So these kind of people, they are prone to get heat related illnesses. So let's go on and see what are the types of heat related emergencies. And my learning objectives are what I want you guys to, at the end of the lecture, to get a basic idea what are the types of heat related emergencies, as well as how to basically manage those patients when you see these patients at your practice. Right? Okay. Yeah. So heat related emergencies, these emergencies are a spectrum. Some heat related emergencies are very mild, they are self limiting. However, some heat-related illnesses or emergencies, they are very severe and they can potentially fatal. So in Sri Lanka, if you have gone through the heat-related emergency case reports, you can see we have seen many deaths, especially military, athletes, and laborers who exposed to direct sun, exertion outside for long hours, end up in heat-related emergencies, which are fatal, end up in deaths, which were preventable if our healthcare workers, especially doctors and nurses, if they have any good idea about how to basically identify the heat-related emergencies and how to manage the heat-related emergencies. Right? So you all know from where we are controlling our body heat. Let's think about our anatomy period, which we learned during the medical student time, right? So body heat usually regulated from our brain, an organ called hypothalamus. So hypothalamus regulates body heat. It has receptors. So it gets inputs from many peripheral receptors, which located not only the skin, but also in the internal viscera, as well as it can activate regulatory mechanisms to retain heat or dissipate the heat, right? So it's very simple. So heat related emergencies, they spectrum from mild to fatal. And normal person body heat regulated by brain, the hypothalamus. Hypothalamus has receptors which gets inputs and outputs from skin and various other organs. So before moving into the heat related emergencies or illnesses, let's get some basic idea how body regulates our heat. So hypothalamus is the one regulate body cooling as well as heating. So when the core temperature elevated, hypothalamus gives various signals. So the first signal hypothalamus is giving, it gives outputs to blood vessels. So it happened vasodilatation. So the body, the vasodilatation happens, especially peripheral circulation, because body wants, hypothalamus wants warm blood to divert to the peripheral circulation, which is close to the skin, then very easily heat can remove from the body through the skin. But what happens when the body, the hypothalamus diverts this heat to peripheral circulation, patients, they get internal hypovolemia or central hypovolemia. So most of your blood, intravascular volume, it diverts to the peripheries or the skin. So then internally, core level, there can be hypovolemia. As well as hypothalamus is going to activate the sympathetic pathway, and then so which resulting heat loss. Let's move on to the next slide and see. So hypothalamus not only dilating the blood vessels and sending the blood to the peripheral circulation. Now there should be a way that skin should lose heat. So best way is producing sweat. So salt, water. So you all, I think these days experience enough sweating. And because of the sweating, you lose water and salt from the body. As a result, with this water, the heat also removed from the body. So that is one regulatory mechanisms. But amazingly, the hypothalamus can regulate your behavior. So think about these days how we're going to sleep. If you don't have air condition at home, or if you think about your electricity bill, then usually what you do is you will have a cool bath, or you are not going to wear any clothes and blankets when you sleep in these days. So likewise, hypothalamus, when the body temperature goes up, it can change your behavior. So invariably, the person will try to remove from the hot environment and reduce exertion. I think nobody willing to do exertion or exercise these days, especially at the broad daylight. And we happy to wear some cotton thin clothes rather than jackets and blankets, wearing everything, because our behavior is controlled by the hypothalamus. And we always try to find a place to shelter, protect from the sunlight. So hypothalamus, now we discuss how it's going to regulate your body heat. One option is it's dilating your vessels and then sending the blood to the peripheral circulation, and then skin can produce sweat, salt water going out from the body, with that body losing heat, trying to cool, right? It's like the engine radiator. Same time, so behavioral changes. So people tend to find shady places, avoid exertion, removing clothes when they feel warm or when their body temperature goes up. But why the illnesses happen? Because either you supposed to work outside, you supposed to exert outside, then is these behavioral responses initiated by the hypothalamus inhibited by the cerebral cortex. Let's say, think about a soldier who giving some security at the roadside, or policeman who is doing controlling the traffic jam. His hypothalamus also sending behavioral response. Go to a shady place, have a rest, stop exertion. However, you're supposed to do your job. You're supposed to earn money. Then your cerebral cortex is inhibiting your hypothalamus functions and then tend to continue this action. So he's getting sweating. But let's think about if you're supposed to wear a thick uniform and do this exercise or exertion, then your sweat evaporation will impair, right? So then they will drag into this nasty spectrum of heat-related illnesses. So once this temperature increases in the body, apart from this protective response, inflammatory cascade will initiate. So I think you all know when this systemic inflammatory response initiate. One thing is sepsis, other thing is in trauma, as well as when the body core temperature goes up beyond the level of these protective responses from the hypothalamus, body start to activate this inflammatory cascade, which releases mediators, including interleukins, cytokines, and different proteins. So these inflammatory mediators, they're causing an acute phase reaction, which cause increased mucosal permeability, including blood vessels and GI tract. And most of the intravascular volume will lose. And as well as these interleukins and cytokines cascades can cause tissue damage. So now the patient or the person who is at outside, think about the soldier or the policeman supposed to wear a thick uniform, supposed to stand at the middle of the road at the broad daylight around 11 a.m., 1 p.m., and then do the traffic control or do the exercise. His hypothalamic protective mechanisms cannot control his body heat. So inside the body, they develop an inflammatory response. This acute response causing releasing of lot of mediators, interleukins, cytokines, and proteins, right? And then it causes mucosal permeability, and then activate a cascade response, end up in a endothelial and tissue injury. Now they are dragged into the heat-related illnesses. So our body is full of proteins. We have different proteins. We have structural proteins and we have enzymes. All our body functions amazingly controlled by enzymes. So enzymes are proteins. Now these proteins can only act in a range of optimal temperature. If the temperature goes down or if the temperature goes up, the optimal function will impair. And these proteins can denature, especially enzymes, which causing energy generation, ATP production. So most of these enzymes involve in energy production, Krebs cycle, ATP production, and then that will impair. So the cells are lacking anaerobic or aerobic metabolism and end up to a lactic acidosis, and cell death will happen. Not only that, think about how the blood. I think you all know about the clotting cascade and coagulatory proteins. They all are proteins. So when the body temperature goes up, these proteins become denatured, and then it activate clotting cascades, end up in disseminated intravascular coagulation everywhere in the body, as well as bleeding. So clotting will impair all the energy production and regulatory proteins, enzyme proteins will denature, and then patient will gradually walking up the ladder of heat-related illnesses from mild to fatal. If you prevent this vicious cycle as medical practitioners, when you see this patient, he will end up in multi-organ failure, which is like sepsis, and end up with death. So earlier the better. That's why I thought I will select this topic and discuss with you guys today, right? So up to now, we have discussed why, as doctors, we should know about heat-related illnesses very simply, and then what are the ways as a tropical country we live in Sri Lanka, why it's important us to know about heat-related illness, prevalence and incidence. It's very common, but not properly identified as something else, especially managed as sepsis. Coming with fever, managed as sepsis, but it's not sepsis, it can be heat-related illness. And then end up with deaths. Morbidity and mortality goes up. And we discuss which organ is responding for our heat-related regulation, which is hypothalamus, and what are the protective responses, including vasodilatation, sweat production, and behavioral changes. However, because of your job, because of your training, people tend to suppress these protective mechanisms or environmental factors. They suppress these protective mechanisms, which drag the patient to a vicious cycle. Activation of systemic inflammatory responses going to a cascade, denature proteins, and end up in coagulopathy and ultimately death. So let's think about this. Now we know about the physiology, we know about how it can alter, and let's get an idea about how it goes. Right? I think it's clear up to now for you all. So let's little bit talk about the history. It's very interesting. So I did some history literature survey, and then I found out these heat-related illnesses are not new. From ancient age, heat-related illnesses were happen, right? So this picture is for the great Alexander, right? So great Alexander was a commander or leader, conquered one third of the earth few centuries before. He had a army. So this army, they travel on top of horses and fought with other armies and conquered from Europe to India. His notes, and he found out his army men, they were collapsed from the horses, became red, and then got fits and died, especially when they travel at the broad daylight. So he thought he couldn't understand this is heat related illness. But he gave a good command to his army not to travel in the broad daylight. So they wore all sort of heavy garments, metals to protect from shields to protect from enemies, and carry heavy weapons, rode on the horses at the broad daylight. And he found out his soldiers were collapsed from the horses and became red and died from fits. So he stopped marching at the broad daylight, and he ordered to march at the early morning or afternoon. So then from that he prevented losing his soldiers. But this great Alexander, he didn't know he was dealing with the unknown enemy called heat stroke. Right? And I found out another interesting story about heat related illnesses, which I will talk about a little bit later. Think about the clinical presentations. So this is a spectrum. So heat-related illnesses can be self-limiting, mild, or need aggressive treatment and fatal. So it can be prickly heat. So it's the rash. It can be heat edema. It can be heat cramps, heat syncope, heat exhaustion, and heat stroke. Now, I think you all experienced or you all have seen when you students play at sport meets, they sometimes when they run they get cramps. So these also part of the heat related illness. They lose sodium, they lose water, and then they end up in cramps. But if you stop the student or athlete to running and give some salt or sugar containing fluids and put him into rest, it will resolve. And heat exhaustion is still the patient's body regulatory, heat regulatory mechanisms are working, but it's trying hard. So patient is starting to show the features. But heat stroke at a level where the body temperature goes very up, very high. I'll talk about that later. And the heat regulatory mechanisms will stop. Now, that is the dangerous thing, which I want you guys, when you practice as doctors, to think about, am I dealing with a heat stroke? If so, what I'm supposed to do basically, and how I'm going to transfer this patient, right? So heat-related illnesses are a spectrum which can start from small rash to heat stroke. Heat stroke is fatal and deadly. Usually patients, if you don't treat timely, appropriately, patient will end up in death. But heat rash will resolve, right? Even you don't treat, when the environment temperature goes down, or if you have a good bath every day and apply some cream, then it will go down. But heat stroke is deadly. So this spectrum, we have to be cautious and find out where our patient standing, right? So let's move to the another interesting story. Anyone knows who is this? Now this is called broad daylight witch. She's a witch. She cursed to the ancient European farmers. So the farmers found out they worked Europe, the farmers worked in the wheat fields, and then they found out during broad daylight, their co-colleague farmers, they collapse and they become delirious. Delirious means they get confused. They see abnormal things like ghost, and then if they get seizures, and then they die. So they couldn't find out what's happening. They thought there's a witch coming and cursing them during the broad daylight. So they named this ghost as broad daylight witch. Then what they have done is they want to protect from this ghost. So they decided we will not work at the broad daylight. So they stopped work around before the sunrise, before broad daylight, and then got together, sat down, had some water, rest, and then restarted work a little bit afternoon. So from that, they thought they got the protection from this ghost. Now, actually, this ghost is heat stroke. So when the patients get heat stroke, their cerebral perfusion will go down. They'll develop a cerebral hypoxia. And because of these inflammatory cascades, they become delirious or confused. They can see abnormal things. They are not oriented. So that's how now initially I talk about the great Alexandra. Now this is about the broad daylight ghost or witch who cursed the European farmers. Actually, these are heat strokes. So it's very interesting. And heat stroke happened previously in the past as well as happening every day. And if we miss, the patients will end up with this curse of the heat stroke. Okay. So what is heat stroke? Heat stroke, your body temperature goes up to a level of 40 Celsius, 40 degrees Celsius, or 104 Fahrenheit. So when if a nurse comes to you and say, doctor, the patient's temperature is very high, right? From your mind, at least think, am I dealing with heat stroke? Can this patient prone to a heat stroke? What was he doing outside the hospital before he's coming? And usually people with heat strokes, they're delirious. They're delirious. They get central nervous system dysfunction accompanied by a systemic inflammatory response. So patients are very irritable, confused, agitated, not oriented. And sometimes they can come to the hospital with a generalized tonic-clonic seizure and end up with encephalopathy and coma. So heat stroke is the thing you should not miss. It's very common, and Sri Lankan population, they're very prone to heat-related illnesses, which are poorly managed, poorly identified by the healthcare workers in Sri Lanka. So they confuse it with multiple other differential diagnoses. Usually, most of the patients I have seen, and according to literature, manage as sepsis. So high fever, irritable, confused, agitated. Usually they get broad spectrum IV antibiotics. That is all right, giving IV antibiotics. But however, they need cooling. Right. Yeah. So if you see a patient in your emergency department at the field, especially when you attend to a sport meet or in your general practice, who's coming from exposed to broad daylight or coming from exertion with confusion, please send him to the emergency department. Don't send him home. It can be heat stroke or it can be something else, so head injury or sepsis. But then you have to direct them to a hospital. They usually develop shortness of breath. They are dyspneic because of the systemic inflammatory response, as well as when the body temperature goes up, respiratory rate will go up. They try to increase tidal volumes to lose warm air, body temperature, as well as to counteract the hypoxia. But if this keep on going, they end up in seizures. So that is deadly because your body temperature already goes up. And on top of that, your body getting electrical activity in the muscles and getting seizing. So seizures with progressive continuous muscle activity generate further heat, worsening the lactic acidosis. Then if a patient with heat stroke not treated appropriately accordingly, he will end up in seizures, then very difficult to save that patient. Very difficult to save that patient. So we have seen many heat stroke. I have seen personally in Australia as well as in Sri Lanka. So we have mechanisms to identify heat stroke in Australia. So it starts at the paramedic level, at the field. They always think and try to do some preventive measures as well as treatment measures. So let's begin that in Sri Lanka as well. So if you get a patient, athlete, marathon runner, military soldier, army person, police officer who came from duty, who came from the sports meet, who's coming from the field with confusion and increased temperature, am I dealing with heat stroke? Think about that very well, right? Okay. So let's move on. So heat stroke can happen in two ways. One is exertional heat stroke. Other one is the classic heat stroke. So don't think only patients who are running outside, attending to marathons or military exercise will get heat stroke. No. So there is a non-exertional heat strokes as well, which means even the environmental temperature is not very high. However, if the patient's having a chronic illness or on medications and his heat regulatory mechanisms are impaired, they drag into heat stroke, which is non-exertional. So if you get a patient who is on medications such as diuretics, aspirin, Disprin, NSAIDs, then think about non-exertional heat stroke, right? As well as if a patient, bedbound patient, having a stroke, hypothalamus not working properly, then think about heat stroke, right? And especially these days, I have managed patients who are coming with recreational drug use. There's a trend of using recreational drugs, sympathomimetic drugs such as ice, ecstasy. And the market, there are different names, magic mushroom, and different recreational drugs, which cause activating of the sympathetic system. And they tend to dance. So I have seen three patients who are coming after a night party who danced inside a confined room with another 100 to 150 people. And they have taken these recreational drugs. And then the dance started at around 7 p.m. up to early morning. A room or a hall where there's no enough ventilation. So all three came with confusion, difficulty in breathing. Body temperature was around 39, 40, 41. And then all three died. We have given aggressive resuscitation, but all three died. So if you get a patient who is coming from a nightclub or attend to a party and then coming with sweating, confusion, and check the temperature, if it is high, that can be heat stroke, unlikely to be a sepsis. So think about that. Think about that, right? So heat strokes or heat illnesses not only happen with exertion. There are some non-exertional heat stroke as well. Okay. So how to manage? Now let's come to the management part. Now we know from up to now we know. So I was talking about the investigations that you're supposed to do when you're supposed to do when you get a patient with heat stroke. So you have to do a capillary blood sugar, and better to get an 12 lead ECG because they develop a lot of arrhythmias, especially tachyarrhythmias as well as bradyarrhythmias. Then you can do the basic blood test, including full blood count. You might see hemoconcentration, and HB might goes up, and then you can see raised white cell count because of the inflammatory response. Better to do the electrolytes. There can be hyperkalemia because of the muscle activity. You can get potassium, intramuscular potassium to coming out. And there can be, you have to do the renal function test. They can go into acute kidney injury. You can say, if you have, you can send the liver function test because they can enter to liver failure as well. And clotting cascade because coagulated proteins can denature and they can end up in DIC. Creatinine kinase can be normal or elevated in it. So imaging, you can do a CT brain if you want to exclude any other intracranial pathology, as well as you can do so ECG I told before. Now let's move to how to management. So this is very important. If you suspect heat stroke, don't let the patient to walk. Don't let him to run around. Ask him to sit down or lie down. Remove from the hot environment. Switch on the AC if you have in your hospital or your GP practice, or put at least a fan towards the patient. And take off, maintain the privacy, have a chaperone if it is a female patient, and try to remove the extra clothes. Stop voluntary activities. And then most important thing is the cooling. So cooling, there are two ways of cooling, external cooling and internal cooling. I will show you a very interesting photograph. This was taken during the Second World War. So I think you all can see. This was taken during the Second World War because most of the British soldiers who fought against Germans, they affected this heat stroke. So they had a unit to cool the patient. So you can see the patient lying on the bed. Lying on the bed, and he's not walking, running around. And then they have taken off their clothes, most of the clothes from his body. So he's on a small bed, and one person is pouring cool water to him. But make sure that you don't pour the water into the face that they will aspirate, but he's pouring cool water to a patient's body. So you can do this in your emergency department. You can do this in your ward. You can do it wherever you practice. So if you suspect heat stroke, let the patient to lie down, take off the extra clothes with a chaperone and privacy, cool him, open the tap, pour him with the tap water or cool water, which will help to wash out the sweat and then cooling the body. So you're externally cooling this patient, right? This is something you can do, you guys can do, right? So cold water immersion, something you can practice. There are ways of internal cooling. So you can give cool oxygen, you can give cool IV fluids. Usually, if we suspect heat stroke, we put normal saline into a refrigerator, lower compartment, and cool and we give. And then sometimes you can irrigate the bladder with a catheter with a cool saline. Sometimes they put a intercostal tube and cool the thorax, but those are invasive internal cooling, but you can do the external cooling. And same time, if you can switch on a fan, then patient will benefit from the cooling. Right? So you remember this picture. So how they are cooling soldiers. This was taken few decades before. And you guys know where the more commonly people affect from heat emergencies? That is in Saudi Arabia, because uh, Muslims, they come as pilgrims to Mecca. So they, because of the congestion, because of the Saudi Arabic environmental temperature is very high, so people tend to get exposed to sunlight and end up with heat illnesses, especially heat strokes. So they have the most effective cooling systems designed by the Americans. So they cool the people. They cool the people. They pour the cool water onto the people who walk exertional to pray for their religious activities, right? So you can use cold IV fluids for the patients I mentioned who came like a few years before from a nightclub after dancing. So we have given cool IV fluids, multiple bottles, but they all died. Right? You can use cool IV fluids and body cavity lavage, bladder, NG tube, and giving cool saline water. And peritoneal cannula and giving cool fluid also can be tried, but those are invasive methods. But I think primary care medical officers, you guys can cool the patient external cooling for sure and give some cool fluids also fine. But make sure that you are dealing with sepsis, not sepsis as heat stroke, right? It's very important to identify the patient. Now let's go to the prevention. So prevention is always better than cure. So you can give advices. Now look at this athlete. So this athlete is at the broad daylight, but she is drinking a lot of fluid and rest appropriately for the sport event. So when you advise, somebody asks advice from you, when to organize marathon sport meets, don't do that in February, don't do it in August, and try to start that early in the morning around 6 a.m., 7 a.m., and then finish it around 11. Or give a rest and divide it your sport meet or marathon, whatever, two events, morning and afternoon. Don't let them to run at broad daylight, expose into the sun, exertion with muscle activities, and end up with heat stroke and end up with that. And make sure they get adequate fluid, hydrate, not only exertion, and make sure you all and your family members drink enough fluid these days, because you can prone into heat illnesses and dehydration, right? Which has some salt and salt, electrolytes and sugars. And the polypharmacy, this is done by us. So polypharmacy is a common factor that can happen. Uh, so when you prescribe, don't prescribe multiple aspirin, dysprin, and analgesics. Don't prescribe multiple diuretics, right? They can go prone to heat strokes. So polypharmacy is a thing you have to avoid when considering about heat-related illnesses. And this is some newly devised cooling stuff around the body. So this is a cool garment which designed for workers, especially in developed countries, when they work at the broad daylight. This garment will AC their body themselves, right? So I think this is a new inventions to prevent heat strokes. And there is a place in our home, in our working place, that we can prone to heat stroke. That is your vehicle. So I think you all park your vehicles these days outside the hospital, outside the house, or inside the garage. So outside temperature can be 25 Celsius, but inside the car temperature will go up to 55 Celsius. Can you imagine? Have you ever tried to measure the temperature inside your car when you're coming after day shift and getting into the car? I think you will understand. Even you switch on the AC, even the shutters are down, it's very difficult to stay inside the car for some time, right? You have to start it and run some time till the AC is function fully. So make sure that when you park the car, don't jump into the car or don't stay in the car for a long time if it is parked not in a shady place and outside exposed to daylight, because your car inside temperature can be 45 when you're coming in. And if you dehydrate, exhaust from your shift, work hard, and then you are prone to heat illnesses, right? Especially don't keep your children or anyone else children. Now this is considered as a crime in Australia. If you keep your child, close off the shutters, put him onto the child seat and go to supermarket or something, the parents will be charged by the federal Australian police against the criminal law, right? So you can't do that. Children are small, their body surface area large, they are prone to their heat regulatory mechanisms are not well developed. They are very prone to heat related illness. If you get a patient or child bringing by the parents saying he was with me inside the car for some time now having fever, can it be a heat stroke? Yes, it can be. Think about that, right? Okay. Now that conclude my first part of the lecture of heat related illnesses. Now we'll move on to basic life support. Only few slides, then we can finish off this CPD activity today. So up to now, I will re-summarize. So we have discussed about the heat related illness. That is a spectrum of diseases. It's very common. As doctors we should know, because we live in Sri Lanka, we practice in Sri Lanka, and we know about body heat regulatory mechanisms, and we know how it can dysregulate, and what are the things that we have to consider, how we investigate, how we manage, and not to miss heat related strokes. And most important thing, prevention is better than cure. So prevent it. Advise your patients how to prevent it. It's very easy. And if you and show them the gravity of these heat related illnesses, right? So let's move on to the last final part of my lecture. Now, patients can go into cardiac arrest because of the heat-related illness. But let's see, if you see a patient outside a sport event, patient is not responding. Not responding means you talk to the patient, he's not responding, you move him, he's not talking. So how to basically approach? This is basic life support. I thought to join this part because that is important. Even though it is heat-related emergency, heat stroke, patients can become seizures and unresponsive, and they can go into cardiac arrest, right? So first thing is you talk to the patient is not talking, then you move the patient from the shoulders, he's not responding. Then you have to check whether patient having respiration and pulse. So you can use the look, listen, feel method. So this picture clearly elaborate. This healthcare worker, this lady doctor, looking at patient's chest, and same time try to feel the warm air coming from the patient's nostril, as well as listen to the breath sounds. And same time you can check the pulse from the hand she's holding the chin, you can keep it on the neck and check the pulse. If there's no pulse, no breathing, uh, then you check the response, open the airway, check for breathing and circulation. If patient having breathing and circulation, then you can progress. If not, patient is in cardiac arrest, right? So then first thing, you are not going to manage any emergency alone. Call for help. Call for help. Emergencies, nobody, even emergency consultants manage alone. You need help. You need support. Call for help, right? So even heat stroke or heat emergency or any emergency, please call for help. At least if you can take home that message, I'm very happy. Call for help. Don't hesitate to call for help. And then chest compressions. You can give chest compression, interlocking the fingers, keeping at the lower half of the sternum, 100 per 20 per rate per minute, and chest compress 5 centimeter depth and recoil. So this is a life-saving thing. All healthcare workers, not only healthcare workers, general public should have an idea about basic life. So make sure you call the research team, call help before you starting anything, and then you can give chest compressions, 30 chest compressions to rescue breaths. And now the trend is we are trying to get the automated external defibrillators, which is designed for general public. So in Australia, in UK, bus stands, railway stations, and most of the places they have automated external defibrillator, which is designed for general public. They have an idea. Only what you have to do is connect the patient to pads, and the machine will instruct you. When you give the chest compression, machine will ask you to stop, assess the rhythm, and then you can deliver the shock. So rhythm assessment will done by machine. This is a little bit expensive, but current trend is in future, I think we can get it done. Still, Sri Lanka, we have this stuff, especially in the parliament. Some five-star hotels, they have automated external defibrillators, but it's not available for general public. But in with time, I think Sri Lanka will get it. But it's very commonly available in abroad. It's very simple to use. This one, automated external defibrillator. So ideally, whatever if they have a sports event or outside gathering in foreign countries, it's mandatory to have a AED close by with an ambulance. It's very easy to operate. Finally, so I'm going to conclude my CPD lecture today. So this I want to finish it with this photo, right? So it's all about talking with each other, getting help, heat emergency, any emergency, or even a managing a patient. Talk with each other, get help from your medical team. So now this team has senior people, junior people, the nurses, doctors, healthcare attendants, wardsmen, radiographers, but it's a teamwork. Emergency management is a teamwork. So you have to talk with them, appreciate what they're doing, and you can give constructive criticism or feedbacks. But it's a teamwork, right? So make sure that you call for help and see any emergency patient as a team. So that is my final message. So today, final summary, we learned about heat-related illnesses and basic life support, why as healthcare providers should know that. And finally, if you can't remember anything, just remember this photo, get help, talk with people, approach patients as a team, right? So that will change the patient outcome. So I will conclude my lecture. Thank you very much. Any questions?
Thank you very much, sir, for your valuable and detailed lecture. There are some questions we have received. I think you have answered most of the questions from the list, sir. Anyway, the first question is,
Yes.
What is the management of malignant hyperthermia?
Okay. So malignant hypothermia is not heat stroke. So that also your body temperature can go up, but that is a very extremely rare condition. So there's a drug called dandrolene, but it's not commonly available. It's available in the national hospital. So usually management is the supportive management, right? So that happen basically to anesthetic drugs, but the management is supportive management, right? So you give oxygen, you if patient need ventilator support, intubate, give fluid, monitor urine output, correct the electrolytes, and yeah, so it's supportive management. Specific drugs, it's not commonly available, but you can think of giving, but it's a very rare condition. Okay, let's move to the second question.
Thank you, sir. So the second question is, what are the types of fluids contraindicated to be given to a patient with heat cramps?
Heat cramps.
Yes, sir.
So heat cramps, usually you can give oral fluids, but don't give plain water. So pure water, better not avoid because it doesn't have electrolytes. So you can give fluids which has electrolytes and sugar. But in the sports meets, so prevent children or students drinking plain water. It's not contraindicated, but better to give fluids which has electrolytes and sugars. Okay. We'll move to the third one, Sajid.
Thank you, sir. So the third question is management of heat shock.
Heat stroke,
Shock.
heat shock.
Yes, sir.
Yeah, heat shock is something like a heat stroke. It's again the management is supportive. Take the patient away from the warm environment, take off the clothes, and then cool him and give fluids. You can give IV cool fluids. You can give boluses if the patient is in shock. Try to maintain the mean arterial pressure above 65 millimeter mercury, MAP, and then support the patient. So you treat as a shock. Only thing with that you have to combine cooling. Okay. Yeah.
Thank you, sir. There's another question in the
Yes.
chat box, sir. What is the management of heat rash?
Heat rash. So
Yes.
basically, you can give advices for behavioral. So you can ask child to have a bath. Parents can give a bath every day, and then encourage them to wear cotton clothes and avoid them running around and exposed to direct heat. And then there are some lotions available, calamine or whatever lotions you can apply, and then basically it will go down, right? But make sure that it will not get secondary bacterial infection. Sometimes it can get secondary bacterial infection, which need antibiotic creams to apply. However, heat rashes, usually we all had heat rashes, but with time it will disappear. But only thing that it has to be very clean and body has to be cool. Especially children, if they can have a cool bath or at least a body wash afternoon before their bed, and then dress them with a cotton cloth and switch on a fan when they sleep and hydrate them well, it will disappear. Right? Okay. Okay,
Thank you
Sajid.
very much, sir. Uh, Now, sincere thanks to you, sir, Dr. Varuna Madhushanka, a consultant emergency physician from National Hospital Accident Service, Sri Lanka. Thank you very much, sir, for your precious time and
Thank you.
that informative lecture. All the participants can follow the link given in the chat box to obtain your e-certificate for participation. Thank you.
Thank you, Sajid. So we will conclude now. Thank you very much.